You're live. All right, so this is Senate Health and Welfare. It is still April 9th. We are. So thank you for being here. We're getting a quick look at what's happening with the Rural Health Transformation Grant. And I will say this right up front. Every time we talk about doing anything, either in appropriations or in here, the comment is, well, won't the grant take care of that? Or, how does that work with the grant? And I am as guilty of asking that as anyone else. And also knowing, from my perspective in approach and then trying to integrate budget here, that decisions were made in the budget before the grant became a reality. So we're just trying to sort out what's happening so we can have a finger on the pulse. That's it. Absolutely. I appreciate you coming in.
Well, we're glad to be here. I'm going to introduce myself and a new team member too. So we'll introduce ourselves then.
Okay, go right ahead.
So I'm Jill Olson and I am the Medicaid and Health Systems Director.
And I'm Sarah Rosenblum. I'm the Interim Director of Home Care Reform.
Sorry,
What's the difference? Hello, Samantha Heffron. I'm joining this team this week as the Rural Health Transformation Director. And I come from over a decade of experience working in with the state, supporting other AHS projects.
Excellent. Thank you. Yeah, thanks for being here.
So we are thrilled that Samantha is on board.
Good.
Yeah, it's going to be great. Both my brain on the project. So we're really excited. So I don't have new slides, partly because this happened a little bit last minute. We have to get all our slides approved. So I only have old slides.
It's okay, but you'll be, what you're saying will bring us up to date.
Yes, exactly. So I'm going to just remind you of a few things. I'm going to show you some old slides, just remind you of things, because I'm guessing you've thought about many, many other things since the last time Sarah and I sat in these chairs. And then I'll go over, we'll go over some of the things we want to update you on and take your questions, of course. Okay. So just to orient all of us. So the Rural Health Transformation. Hello, nice to see you. Rural Health Transformation is a $50 billion initiative from the Centers for Medicare and Medicaid Services, and it was passed as part of the reconciliation bill in July. And its focus is really on improving access to rural health care. Our first year award, we're going to get a different award every year, potentially. And our first year award was $195 million plus. You can see it on the slide. And what I always say about this, I think is good for people to remember, is that the way the program worked, we had $100 million that we expected every state would get. And what was that question was how much states would get up to 200 million. So we were asked to apply for 200 million. And that was sort of that second 100 million was the competitive part. There were parts of the application over which the scoring over which we had no control. So there were measures of how rural Vermont is that were that they were what they were, and so we did not expect to score especially high on the way that CMS was using metrics, their rural metrics. We also didn't expect to score very high on some of the policy initiatives that the administration hoped states had. And so the only way to get from our 100 million to our 200 million was the strength of our application. So the fact that we came as close to 200 million as we did, I think speaks to the strength of the application. Now, some states got more. Texas got more, like $280 million, but some states, bigger states than us, got less. So on a per capita basis, we had one of the highest per capita awards in the country. So it's great. It's great news for Vermont. We always talk about the award type, because I think it's really important for people to remember sort of the world that we're now living in terms of managing these dollars. Rural Health Transformation is not a grant. It's known as a cooperative agreement. And that means a high level of interaction and scrutiny by CMS on everything we do. So what we've been working on, especially as recently as this week, is making sure that CMS has approved release of all of our funds. And all that means is we're allowed to write RFPs and grant opportunities based on those dollars. We can't If there's a line item that hasn't been released, we can't offer the opportunity. So our focus this week has been on getting final dollars released, and I can talk a little bit about, we will get into why some of those were held up. But they will be approving every single subrecipient grant, every single contract we sign, every payment model we put out. They will approve all of those things, or they're subject to approval, right? They approve them all. So there's going to be a pretty detailed process in the next phase as we start moving into having actual awardees for these dollars. So I just think it's important to understand, like, there's just this, like, there's a lot of back and forth. We need room to negotiate with CMS. They may ask us to make changes. And I think that means it's really important to keep the authority like where it is with AHS, because we need to be able to do the back and forth.
We aren't interested in changing that. Do you want us to change it?
No, no, I just like to mention it just in case.
Talking about
And then, so we have an annual report that's due on August 30th. And that report will be the basis, we expect, of our second round of funding that will begin on October 1. So we'll be in year 2 as soon as October 1. So that's a deadline we're really focused on in terms of getting dollars appropriated or obligated, and really being able to also meet some milestones that CMS has laid out that I think all states are finding a little confusing about how we're going to demonstrate compliance or that we hit the milestones. So I think it doesn't sound like it's just us. So we expect more work on that with CMS. They have been pretty good about providing new guidance. We have to obligate our funds by October 30th, but of course that means we have to do all this negotiating with CMS in order to have a fund obligated. And then once obligated means a contract is signed, a subrecipient is signed. That's all it means. There's another 11 months to spend the dollars. So we're spending the first year money until September 30th of 27. And anything that we got awarded this year that we can't spend, and this is true for all states, back in the pot for redistribution in year 2. And, the first year is a bit of a planning year. And so I do think it's likely that dollars from states are going to probably end up back in the pot. Anything I missed on that?
they go back in the pot at the federal level.
Yeah, and then they're redistributed for year 2.
Appropriated.
For year 2.
Yeah.
Every state gets rescored every year.
We don't reapply every year, we get scored every year.
Scored against like our progress on the original application and get a new award every year.
Yeah, and the interesting one is the deal with FEMA and obligated funds and all that nice stuff. So once you get obligated, you're pretty much guaranteed the funds, I guess, except if you did something outside of the scope of what you were supposed to do. Am I saying that?
Yeah,
correctly?
I would say that's right. Yeah, there's an expectation that the plan that we submit is the subrecipient grant submitted is what we'll do. But yes,
But say,
obligating should be.
exactly, but not guaranteed is what the other stuff. It's obligated, it's not guaranteed. But if you did do something that didn't fit to your scope or whatever like that, they could grab those dollars back. I
I'm
think.
sure they could.
Oh.
Yeah, I think so.
Yeah, I think that's very unlikely, even from even from an AHS like compliance perspective. We want people to be doing the thing we.
Yeah, no,
Right, exactly.
absolutely.
Yeah.
I absolutely.
Right. Right. And I think the one thing that I do feel like is that because it's a cooperative agreement, because we're going to have all this back and forth, because they're going to approve every single individual budget to every subrecipient, that should make it much more clear that we're on the same page, so that aren't surprises after the fact about whether or not we did what they thought we were doing, right? Because they're going to have signed off on everything.
Yes, the only part of the award that CMS has explicitly said is up for clawing back is if we don't achieve our policy commitments.
Right.
You don't get your outcomes.
No, just any policy. Some states made a lot of policy commitments.
Yeah. So if you wrote in your application that you were gonna change your certificate of need law by a certain date, which we did not write. Sorry, I was just using an example. and you don't achieve that, CMS has said, we will come after you for the dollars back.
From the original ones, yeah. Okay, so I just like to always go over the application parameters. The application, when we submitted the application, there were a lot of different parameters outlined. And we try to think of these dollars essentially as one-time funding. So we're trying to use it to launch things, to transition to new things, to buy stuff. It's not 100% that, but that's the idea, because we're really trying not to build to the base. We're trying to have a sustainability plan for anything that we put forward. So we may start up things that, for example, then have an opportunity for a provider to do some billing, and then it becomes sustainable through the sort of normal reimbursement mechanisms. But we might have helped get it launched.
But you can't obligate a future, budget.
Right, that's right. So there's some big limitations. We cannot supplant the state budget. So you can't say, we're gonna cut this, we'll just pay for it with our HG. Can't do that. We unfortunately have real limits on the kind of construction that we can approve, which is too bad, because construction would be a great use of one-time money. But CMS has said that it has to be limited to changes that don't increase the value, the property value. So that's pretty limiting. So we could like maybe move some walls around to get a new piece of equipment in, but there's a refurbishing is not really in the cards. Which is too bad, because there is a lot of old infrastructure in Vermont that I'm sure we could use these dollars for. Okay. Present company excluded.
No, I'm just thinking that, you can fix up the inside of your house and you don't have to let the assessor come in. So-
Okay, I'm not. My goodness.
It's really good.
Wow, okay. Okay, and then we also can't fund otherwise billable services that are already being reimbursed. So we can't actually raise rates. We can't fund things that can be billed. It looks like we can initially fund things that are billable while we figure out how the payment is gonna work. I think we can do that. Sarah's looking at me like, maybe.
Okay, so that's there and.
We can start things up, but billable services have to be billed.
So I know there's some language in
Yes.
in RHT that relates to primary care and blueprint.
Yes,
And we would like to put additional funding in for primary care, just as one example.
Yep.
So how can we do that without crossing a line?
yes. So, yeah, we can do those payments that we put in because they are not billable services. That's the reason.
They are like per member, per month payments that aren't tied to specific services, but are tied to community health teams or to practices that participate in the blueprint. And so because of that, it is different from this rule.
Yeah, they're not considered billable. Where it does start to become an issue is the next bullet, which is that provider payments cannot exceed 15% of the total award. And that's gonna
15% of the total.
award.
Oh,
So it's about
yeah, right.
$29 million
Yeah.
in year one. As far as we understand, it's gonna change every year, depending on the size of the award.
Yeah.
And so we were waiting for a while for CMS to clarify for us what provider payments meant to them, how they defined them. And there were three categories of our three projects, numbers 4, 20, and 21, that were held up because we weren't able to provide a justification to CMS because we didn't have the guidance from them. So it just was a little bit of a waiting game. So they held them up because they thought they might be provider payments, and we couldn't answer the question absent the guidance. So we now have the guidance, and essentially CMS has said if you are using if you're using the dollars to take care of a person, that is pretty much a provider payment. So something that would be,
That's okay. That's a PM.
that is a provider payment.
Yeah.
So
that is a
that's a provider payment. It
Oh,
counts
that's
against
bad.
the cap. That's
Okay,
from cap purposes, accounts for the cap. Yep.
okay.
And also quality incentives. So certain kinds of incentives also count toward the cap. So we worked through looking at the different PMPMs and we were able to get, we've had some back and forth emails with CMS and we believe we now have agreement about which ones, and it wasn't all of the PMPMs are provider payments and which ones aren't. We also asked them a question about another project that we're doing that I'm not sure it's going to launch this year, so it's probably not relevant this year, but it may be how it's been viewed in other states, because it's something that other states have done, so we may have to rejigger things yet again, but not right now. We're just trying to get the dollars released.
So the remaining funds that we have that are restricted still by the federal government are all restricted because of this provider payment cap. Concerns about that. As Jill said, we have a solution. We think we're going to submit a budget revision this week, which will hopefully be approved. And then the restriction will be lifted, and that would be all of our funding for this year would be unrestricted at that stage.
Wow, okay.
Yes.
Interesting. I wasn't aware of that. So we're looking at the physician bill, basically. So the PMPM per member per month. And you're going to get around $29 million that you can put towards what you want, as long as which is 50% of your total award. Right. And then my concern it will be after 5 years, you lose
Sustainability.
that. So I just don't want you to
Oh, yes,
massive problem in 5 years.
yes, no, I think that's something that's top of mind. We did talk in the application about, hoping that we can transition back to having some kind of federal model where there's Medicare participation. That's how we had done it in the past. We're between federal models right now. And so part what we're trying to do here is make this work while we're between federal models. That's one of the ways in which it potentially fits into other types of initiatives, but that's a whole other day.
It's another week of work.
Yeah. Okay, these are our initiative categories. This came up, we were just in the house just a few hours ago. So CMS has said that we were just in Baltimore 2 weeks ago, 3. I don't know. Or I'm not sure. No longer oriented space and time, neither one of us. But we were in Baltimore, and one of the things CMS really emphasized, the officials who were there, was the plan is the plan. What we said we were going to do in our narrative is what we are executing on. We're not doing new things. We're doing what we said we were going to do. That said, these are the initiatives that CMS thinks of our work as both in these 5 buckets of initiatives, and then they think of them as individual activities underneath the initiatives. And so what's not as clear to me at this moment in time, and really we're not even exploring it, is the extent to which there'll be any flexibility within an initiative as things roll out, or maybe sort of roll out and are completed in future years. I think all states are going to be asking that question. Nobody's asking that question so much right now that I know of, because we're all focused on the plan that we, as we have already promised it.
Are you adhere? I mean, I have the initial of the 5 with your
All of our buckets.
Yeah. Are you still adhering to that?
Yeah, we are making changes on the budget side. So we're making the change this week, as Sarah said, on the provider payments to get that adjusted, to get those funds released. That actually changes words, I think, but not number. Oh no, it changes words, but not totals.
And it doesn't change projects. It's literally like,
We're sort of saying we're
Linguistics.
clarifying certain things, what things are. Because it pulled one thing out of the cap, it did leave one thing in, or 2 things in. But then, where was I going? Right. Oh, but then so the other thing that's happening is we've been working on actually developing RFPs and notice of grant opportunities. So our various departments, including the Office of of Healthcare Reform, but also Dale and DEVA, other departments within AHS have been assigned the responsibility for implementing some of the projects. And as the teams of subject matter experts have dug in to the project, sometimes they're finding that we didn't budget enough, or we budgeted too much because there needs to be more planning this year, and we probably won't be able to spend some of the dollars till the second year. So we're seeing some ups and downs. And while we have some flexibility for ups and downs, we can actually adjust with up to 10%. We think we have enough that we're going to do a new approval process with CMS to adjust the budget, which we expect will. They know it's coming.
So they're okay with.
Well,
We
we
hope.
won't know until we've done it, but they are aware that we have that in the works. I can't imagine that's not common among
Yeah,
states.
probably
I mean,
every state is doing the same thing.
It was such a fast application project that, you know, there was a lot of estimating that had to be done. And, you know, once you get closer to it, I think it just, you know, more is revealed to
Right.
us.
Well, you get down into the details and you. know,
Yeah.
Yeah.
Questions, go ahead.
Are you gonna share with us the list of RFPs that you're gonna put out so we know
Yeah.
what it is?
Yeah.
Okay.
Yeah.
There,
I'm gonna tell you where to find them. I don't have them on the slides because of my requirement to have slides pre-approved, which I don't have time
Understood.
for, but I
Got
do
it.
have a list and we do have a website and they're on the website. So I'll get it there, I promise.
the website is good.
Oh, thank you. I don't know why I'm, yeah.
I like to hear.
Yeah.
Yeah.
Okay. I'm not gonna go over this. This is just sort of our quick, this is the initiatives and these are the official categories. This is more how I bucket it in my head for what that's worth and some examples of some of the projects. I'm not gonna stay on that one, very long today. So getting to your question, so we do have an RHT landing page. So if it's a website, and it has a few things. It has a public contact form, so people can email us. It goes to a dedicated inbox that, I don't know, 5 or 6 of us have access to. Sarah pretty much is the key monitor right now. And we actually use it both internally and externally. That's where all the questions come to us. We really are trying to be the central repository for questions from team members within NHS up to CMS. So that's the place that we communicate from. That's where we get information in, but it's also the contact form on the website goes to that same inbox. So we are receiving information there. And then also on the website is our project narrative, like literally the application we submitted, a very short summary. And then what I'm finding is the thing people seem the most interested in, which is a list of projects. And so it's a list with a short description. And so it's just, if you're interested, people who are interested seem to sort of like that one the best because it really gives you some granularity without having to read this 60-page application where things are duplicated and confusing just as the structure of the document. Also on that page are instructions for signing up for our email list. So we are sending out, by we I mean Sarah, sending out an email blast every week, letting people know which RFPs have been released. So one thing, I said this upstairs, that we found was that the provider community and vendor community were really anxious that they were going to miss announcements about RFPs and grant opportunities. And so we're doing 2 things. We're posting them on our website so that if people are thinking about it and want to go look, they have a place to go look. And we are pushing it out on a weekly basis to say, hey, these are the ones that came out this week. I'm going to actually stop sharing and then go to my my notes. Stay on in the meeting though, just in case. So the projects, the RFPs and grant opportunities that have been posted to date are the dialysis ventilator in nursing home project. That was, I think, the first out of the gate. LNA training programs with hubs for nursing homes. Substance use disorder recovery housing, mobile dental and healthcare units, pharmacy test to treat, and then also support for the healthcare delivery strategic plan that's due in 2028. We felt like we needed more help to
Awesome.
to help us. So we put it in into the application and it was approved. So that will give us just more bandwidth.
And
for
that was approved. I mean, you couldn't do that even though we legislated that you have
Yes, we have to spend the dollars you appropriated first toward that effort,
Yeah.
but we're going to need dollars over time, both for the strategic plan. This is really more
an
like
implementation.
someone to help us. Yeah. And then also the analytic vendor
Yeah,
will be able to have ongoing analytics support, pay for ongoing analytics support using these dollars. And that will be actually an extension of an existing contract, because that was already in the procurement process when we started.
Yeah, I was gonna ask that question, so it won't be a new RFP that goes out, it would
No.
continue the contract.
No, so to the extent that we have existing relationships that make sense, we're utilizing them.
Okay.
Yeah. Next up, we have, we've been working kind of in batches. So we have some of the blueprint kind of clinical practice support projects. There's a few of those. And then there's some technology projects, and they've been sort of moving through the process together. They have some interrelationship. And so they're probably all going to go out likely at once.
In the coming weeks, I think there's maybe 10 more that will come out. And so there's 6, oh, is that right? That are out right now?
Yeah.
6 that are out right now. The first
Go ahead.
The first one's closed on Friday, so they were all closed at different times. They have different closure dates. The first one closes on Friday. That the same website that Jill talked about on a previous slide. We have a page on that website that links to all of the active RFPs or NOFOs that are currently public. And it's like cross posting. So some of the departments have posted them, but then we're also keeping them on our RH2P website so that people can just check one place for updates.
And that structure does seem to have, I think, reduced some of the anxiety that was out there. It really seems to help for people to know how to hear about things. So I'm glad we did
How
it.
many responses are you getting for each RFP that you send out?
We don't know yet because they haven't closed
They haven't
yet.
closed. We can't look until they close.
And what's the time frame that you're using for closure?
They're different because it depends on when they went out. So some are closing on Friday, some are closing probably a week later. It's a very layered process,
Yeah.
iterative process. Iterative is actually the word for this.
Iterative is huge.
Yeah.
Yeah.
Yeah, it's kind of a good one. It's really good. Yeah, sometimes it's really what's happening, and this is the case. I think that's everything I wanted to cover. You guys missed anything that?
Yeah, I think, I know you had questions before we went live.
No,
so I
this
wanna
is
make
just
sure-
fine. This is just fine. I understand where you are. I do have my recurring questions about, how can we beef up primary care? And how can we help some of the places that are some of the organizations and services that are already in place, and I'm understanding a little bit more of that is happening. I just have to be patient with it. And then, my ongoing concern about Chittenden County inclusion and where that is.
Yeah.
Is there something you can?
I needed a little more time. We
Okay.
needed to sort out the provider payment question in order to make final decisions about how we were going to handle rurality for every project. And we are thinking about it project by project, but we needed to understand which things were going to be limited and which things were not going to be limited. So we're just getting that clarity. And I think in another week or two, we're going to be able to share more.
Because as I look at the budget and I'm going through some of the downgrade, lowered funding in some of the programs that exist. For example, there's one at the Howard Center for integrated care, basic care for folks for behavioral health through the Department of Mental Health. That's being reduced. It's a really important program, and trying to understand how that could be supported, because there's a whole bunch of people being supported there, and it goes out to some of our rural schools and students in our rural area schools, Bolton, Jericho, Underhill, Huntington. That's the big question. One of the questions.
Yeah, I think there's 2 things there, right? So there's the rurality question, which Jill said we need a little bit more time on, but then there's also, does that cause or project, for lack of a better word, fit within the scope of one of our existing projects that's already been approved by CMS? We did talk at the beginning about the plan. The CMS has said the plan is the plan. Plan that's been approved is the plan for the next 5 years. There's, of course, every project has a certain degree of flexibility within it, but there are also limitations. So the second question is, does that align with an existing project?
I know. a lot
Then,
of
and then
this-
the supplementation risk as well as always.
I look at establishing clinically integrated network of shared services projects and with telehealth, some of these things, regardless of where they are, fit with that broader definition. So.
Yep.
Just,
That's why we're doing it project by project. It's like
Understood.
some things are like, make sense. It's just, there is no rural sort of worry, and other things, it's more of a zero sum game. So
captures our imagination. Okay.
Yeah.
Senator Buick.
Very quick question. Don't answer it if you don't feel like you can or
Oh
should.
boy.
But
I like that for you.
when you're looking at the investments into the nursing homes, are you differentiating between which ones are locally owned, privately owned, private equity owned, or just looking at just, you know, just
So we are not there yet because we're waiting to see who applies to do these projects. So we have not considered that.
Okay, we're getting past our
Yeah, I know,
time.
it's
One
lunchtime.
last question and then we're gonna call it a
Okay.
day.
On transportation, we know there's
Yeah.
a lot about how to get people from home to their appointments. Would that be an eligible cost? But it's not really charged.
Yeah. Good question. It's, and we are not the subject matter experts. I will say at the moment, we don't have a project that pays for transportation services currently in application directly as part of the application. We do have a couple projects that will support our transportation system. So we have a project that is going to support our EMS system. And we have a project that's going to support inter-facility transportation. So if you needed to move from a critical access hospital to a larger hospital, supporting that infrastructure.
Yeah, well, I was just thinking in the blueprint that as we start looking at where services are
Yeah.
provided, those services may no longer be available.
That's right.
in
No,
certain
it's a really important
hospitals.
issue.
So
Yeah.
I would see how that might fit into that.
Yeah,
Yeah.
that's a big part
Yeah,
of
it may work under some of those
We talked
projects.
about that, did we, not the transportation.
Yeah,
it. Mhm.
yeah, and I can talk to transportation.
So we are going to call it a day.
All right.
The-
Well,
we
thank
could
you.
talk- We could talk for hours with you.